Test 1 2. Testing 1 2. Test test.
Wonderful opportunity to come down. My name is Ray Penitentiary. I'm Vice Chancellor for Translational Medicine and Science at Rutgers University. I was also at Penn, University of Pennsylvania for about 27 years. I'm a pulmonary critical care doc who does a lot of research in this space of severe asthma. And let me tell you, this is the best time to ever be treating patients with severe asthma. It's a whole game changer. We're almost like rheumatologists. In the last 3 years, we now have 5 biologics to be used in the treatment of severe asthma. This is a whole new world. And the exciting thing for me is how we're using biomarkers, predictors of things in the blood that will really predict therapeutic response. Now this slide deck was built by my colleagues, Jonathan Corin and Mike Wexler. This is who's speaking today, Ray Penitentiary. And really the learning objectives are focused here. We're going to talk about phenotype, endotype. These are the new terms. Everyone's familiar with phenotype. Those are attributes of a particular patient, but endotype you may not be familiar with. Endotype really talks about mechanism of disease. We're going to compare and contrast biologic agents. We're going to identify patients who may benefit from biologics, and then we're going to employ a stepwise approach in using precision therapy or personalized biologic management in severe asthma. So, first segment is phenotypes and biomarkers. So what are we talking about? The pathogenesis of asthma really has recognized that asthma is a syndrome. It's a collection of diseases, much like congestive heart failure, much like diabetes. You know, we think of these as one entity. They're not, right? There are multiple entities, and asthma is as heterogeneous as these other chronic diseases. How phenotypes and endotypes factor in is what we'll be talking about, the inflammatory pathways, biomarkers, and how we use them. What do you need to know in your practice? So the clinical differentiation of asthma is seen here, and we talk about subgroups of asthma. Now, the characteristics of asthma and the definition hasn't changed. It is airway hyperresponsiveness, most of the time nonspecific. It can occur with cats, dogs, allergens right now in the spring. It's airflow limitation, obstructive pattern, and it's variable in response to its own disease or that of bronchodilators. And the diagnosis still relies on a clinician or a practitioner. We have no genes that determine whether you have asthma or don't have asthma. You really need a clinician to make the diagnosis. Now, it is not a homogeneous condition, as I alluded to. There are multiple areas of difference. The clinical presentations are different. The physiologic characteristics, how one develops asthma is fundamentally different. The time of asthma development is key. Most children who develop asthma are atopic, they're allergic. But as one develops into adulthood or has adult onset, those patients tend to be less allergic. So you're going to see differences with regard to the allergic admixture between children and adults. So asthma, what do you need to know about the pathogenesis of asthma? It's heterogeneous. Every patient's a snowflake. Every patient is unique. And that's really not a new concept in chronic illness, although it's relatively new for asthma. And as a consequence, we really need to individualize our therapy. Now, if I take 2 twins that are identical and separate them at birth, send one to Birmingham, the other to the Antarctic, one may develop asthma, the other doesn't, even though they're identical twins with the same genetic admixture. What am I trying to say? Environment-gene interactions are critical in manifesting asthma. If you're not exposed to the right environmental factors at the right time in life, you may not develop asthma. So it is a gene interaction, and that leads to a variety of proteins, biochemical pathways in cells that render the patient to have obstructive pulmonary function as well as the cardinal symptoms of chest tightness, cough, and wheeze. Now, how often do you see an asthmatic? Really often. In this room, there's 2 asthmatics, I guarantee you. If I go to your immediate families, it's probably touching another 1/3 of people in this group. About 1 in 12 of US population has asthma. So, fitting the individual into a larger group is what we've tried to do. We've tried to make patients look the same. But the consequences of that approach is when we devise a therapy, one size does not always fit. So what is a phenotype? These are attributes of a disease state. An endotype is really where we want to go. An endotype, and this is the new term, talks about a mechanism of disease. If we knew the mechanism that's dominant or predominant in an individual, then targeting that mechanism will have a marked effect in outcome. So, for example, what are you talking about? Eosinophils are very important in asthma. They are a cardinal cell that is seen with allergic asthma in the periphery. Eosinophils survive in the body because of a cytokine called IL-5. If IL-5 is high, the eosinophils live and they go on their merry way. If you take out IL-5, the eosinophil dies. So here's an endotype, a mechanism of action by which if I take out the eosinophil, I could affect an individual's asthma because of the endotype eosinophilic asthma, if you follow that. And that's important because now there are 3 medications, biologics, that target IL-5. Each of these are very effective in those patients where eosinophils are the major culprit in manifesting the disease. All these slides, by the way, are in the handouts. So the separation of asthma into clinical phenotypes, there's a lot of work that's been done in the last 15 years that used what's called unbiased hierarchical cluster analysis. What they do is they take a big computer, they take all the attributes, put it in, and they look for clusters of patients and thousands of patients. This cluster has the following attributes. And some of these are age and gender and severity and physiology and triggers. But you know what? These studies don't get to the mechanism. All they describe is the likes amongst the cluster. We need to move from this to understanding the mechanism of disease so that we can actually impact on the patient. Now, the phenotypes that have been identified are these 5, and you can see some develop asthma early, some develop late, and some have allergies associated and severity of disease, but it really hasn't led to a profound change in our sense. Now, we know, for example, the late onset obese asthmatic is typically steroid insensitive and difficult to manage. Also, the late onset asthmatic in some have a lot of nasal polyps. Nasal polyps in asthma, also known as Samter's triad if you add aspirin sensitivity, are very difficult to manage. But it doesn't talk about the fundamental mechanism behind that. Now, children, there's really only 4 clusters, and the vast majority of these have an atopic or allergic component. I'd say 85% of kids who have asthma also have allergies. What's interesting is these allergic children grow up and their asthma morphs. It morphs from an allergic type to an eosinophilic type. So there are medications like omalizumab, that's a biologic called Xolair, that people started 15 years ago, but over the last 15 years, you see some of these patients now are no longer responsive. That's because their fundamental asthma had changed from an allergic phenotype to potentially a more eosinophilic phenotype. So how do we characterize these? Well, in the kids, you characterize them by the numbers of controllers, lung function, and exhaled NO. I don't know here if you measure exhaled NO. It's a simple test. It measures the amount of nitric oxide that's exhaled. That test is a biomarker, very non-invasive, of ongoing airway inflammation. Higher The higher the number, the worse you are. The lower the number, the better you are. And it tracks with the use of inhaled corticosteroids. So it's actually quite a useful measurement in some patients. So here is the phenotypes of severe asthma. The allergic, early onset allergic. These are patients that are going to be mostly younger patients. Late onset, don't typically manifest atopy or allergy, but also have eosinophils. These are the patients with chronic rhinosinusitis, nasal polyps. They could have aspirin-exacerbated respiratory disease. And the late onset non-eosinophilic, these are the ones that are really troublesome and difficult to treat. And we don't have many biologics there. Now, if we look at all the patients with asthma, what's unbelievably surprising is 40% of all asthmatics don't respond to an inhaled steroid. 40% of patients don't respond to an inhaled steroid. You go, oh my gosh, Panettiere, the guidelines say first drug of choice is an inhaled steroid. The data suggests 40% of patients don't have a profound change in their breathing tests when using an inhaled corticosteroid. The reason I bring that up is we're learning more about the intrinsic inflammation, and one size does not fit all. That's the important takeaway. Now, there are many biomarkers that we can use, but this is an important takeaway. There is non-T2 and T2 inflammation. What is T2 inflammation? T2 comes from the type of T cell that is modulating the inflammation. Th2 is CD4 lymphocytes, and those lymphocytes are lymphocytes that manifest with IL-4, IL-5, and IL-13. This part of T2 inflammation is also driven by eosinophils. This is the one where total IgE is high, and specific IgE by RAS test is high. So, bottom line, for every clinician in this audience, when you see a severe asthmatic, there are at least 2 blood tests you got to measure in every patient. 1, eosinophil count. High eosinophils, greater than 300, mean you have T2 inflammation, and it's eosinophilic in nature. The other test is a total IgE level and specific IgE. Now, if there are allergists in the room, you can do skin testing. Positive skin tests relate to allergy. If you don't have skin testing available, then measuring the total IgE greater than 100 and specific IgE, for example, to trees and grasses, would demonstrate whether the patient's atopic. Now, patients can be atopic eosinophilic, or they can be eosinophilic and atopic. 40% of patients have non-T2. And this, we don't really have much therapy. I'll come back to this at the end of the talk as to what we can do in this case. But it is important to know T2 is steroid responsive. Adding oral steroids or increasing nasal or inhaled steroids impacts here, does not impact in this group specifically. So how do you use these? Well, the inflammatory biomarkers, there's many of them. We can genotype patients, but this has not been revealing, and there's no one gene that tells you if you have asthma or not. Cytokines, you can't really measure these in the blood, very difficult. A lot of variance in the measurement, not particularly useful. Cell populations, yes, in the periphery, the eosinophil count, very useful, over 300. You have eosinophilic asthma. Exhaled NO, simple measurement, tells us if you have inflammation, yes, no. Higher than 30 parts per billion, you have airway inflammation. So this is an easy test. These other ones are thought to be important, but are still investigational and not really available for current use. So what is an ideal biomarker? You know, biomarkers are as difficult to get approved by the FDA as drugs, because they have to be very reproducible, accurate, simple tests that can be done by any practitioner, correlates with the disease severity, and reflects responsiveness. It has to be inexpensive and non-invasive. So when you go through that list, It's tough to get a biomarker approved by the FDA. That's why the eosinophil count in the periphery fits this design quite nicely. So as an inflammatory biomarker, it is a good indication of T2 inflammation. Eosinophils in the blood and the airway correlate with how many exacerbations you have, the degree of airway inflammation, and the presence and absence of chronic rhinosinusitis and nasal polyposis. More importantly than the diagnosis is that we have treatments to take out the eosinophil, and that becomes very, very helpful. So sputum and blood eosinophils do track. Obviously, asthma is a disease of the airways. You would like to know if the eosinophils in the airways are present, not in the peripheral blood. But there is a correlation. Here we're looking at sputum eosinophils and blood eosinophils and the sensitivity and specificity with regard to type 2 inflammation. And indeed, it's very specific. And the blood eosinophils are not bad when it comes to sensitivity in detecting true positives. Takeaway message, blood eosinophils are a good surrogate for sputum eosinophils. And of course, the sputum eosinophils in the airway is really where the action's occurring. But it is a good surrogate for measurement. So let's take a look at this. This was a study done in tens of thousands of patients in the UK. David Price has access to a huge electronic health record throughout all of the UK. And he looked at blood eosinophils and characterized them from 201 to 300, 300 to 400, and so forth. What you're looking at here is the relative risk. So anything greater than 1 is enhanced risk. And you can see when the eosinophils are low in the blood, your risk of an asthma exacerbation that requires an oral steroid, an ER visit, or a hospitalization is less than 1. But as the eosinophils go up, what you can see is the higher the eosinophils, you double your risk and sometimes triple the risk of an asthma exacerbation. So the important take-home message, eosinophils track with sputum eosinophils, and they track with the likelihood of asthma exacerbations. And that's just demonstrated here. Anything in this range puts you in the red zone that you're likely to have severe asthma exacerbations. Now, those patients with sputum eosinophils often have asthma exacerbations. What we're looking at here is non-frequent exacerbations as well as frequent exacerbators. And you can see the higher the eosinophils in the sputum, the much greater frequency of becoming an exacerbating endotype. Exacerbations are a problem. And more exacerbations an asthmatic has, the more likelihood they develop irreversible airflow obstruction, and more likely that they could die of their asthma. So asthma exacerbations are something we really do need to target. Now there are other blood tests that are interesting but haven't bubbled up to be robust and reliable. One is sputum neutrophils. Remember the non-T2 inflammation I talked about? Those patients have neutrophil-driven disease. Unfortunately, very few people in this room, and I included, measure sputum neutrophils. So we don't have an easy measure for this, although it is associated with air pollution as well as reflux disease. But this is non-T2 inflammation and typically not steroid responsive, right? Sputum and blood neutrophils do not go away with high-dose steroids. Other serum proteins are interesting, and some of these, like IL-13-induced DPP-4, are being developed, but they're currently not available for clinical practice. Exhaled NO, we talked about this. Very simple test. It is measured by exhaling very slowly through a tube, much like a spirometer, at a steady rate. You get a specific number out, parts per billion. The higher the parts per billion, the worse you are, okay? So this is golf. all right? Not baseball, football. The higher you are, the worse you are. And what you can see is this exhaled NO comes from the epithelium that is due to inflammation. Now, what's interesting is when the NO is greater than 33 parts per billion and you give an inhaled corticosteroid, it goes down. So you can actually use this as a measure of adherence to an inhaled corticosteroid. Non-invasive and very easy for children to use. So it's actually even easier than doing simple spirometry. Now, going back to the blood eosinophils, one of the important things with blood eosinophils is response to therapy. I mentioned IL-5. Now, we don't measure IL-5, but IL-5 is required for survival of the eosinophils. So if you have high eosinophils, I assure you, you also have high IL-5. The reason this is important is there are drugs like resolizumab, this is an anti-IL-5, benralizumab, or mepolizumab. These all were just released in the last 4 years, 3 different companies, 3 different molecules. And what you can see is as the eosinophil counts get higher, you have a profound change in the FEV1. Why? Because the eosinophil is contributing to the airway inflammation and suppressing the breathing. If you remove that, eosinophils die and the FEV1 goes up. Now, this is really important because for the first time as a practitioner, you can measure blood eosinophils in a patient who get an anti-IL-5 and show that the target has been engaged by the drug you gave, meaning that the eosinophils go away. Benralizumab, which is an AstraZeneca compound, anti-IL-5, has an interesting mechanism of action. It triggers the natural killer cells in our own body to kill the eosinophil. So after one dose of benralizumab, most, if not all, the eosinophils in your body are gone. Gone. Now, doesn't mean that they'll come back if you don't keep giving the drug. But the whole point here is IL-5 is necessary for eosinophils, and as a consequence here, you can see the higher the eosinophil, the more likely you are to have an improved FEV1. So, summary of this segment. Recent evidence and research now shows that asthma is heterogeneous. One size does not fit all. Every patient is a snowflake and an individual. Clinical characteristics of the phenotypes, age, gender, all of these give us an idea but not a mechanism. Using biomarkers can identify type 2 asthma. What 2 tests are you going to measure? Total IgE RAST and the blood eosinophils. If those are high, you're atopic and eosinophilic, you're going to be more responsive to an inhaled steroid and to an anti-IL-5 drug. Discovery of new biomarkers are currently being developed, but not currently available. So now let's move on to novel treatment options. And we're going to talk about the latest biologic therapies and differentiate the mechanism of action of these therapies. So, stepwise approach. I mentioned that 40% of patients don't respond to inhaled steroids. It's still the cornerstone in the management of patients. So it is helpful to use an inhaled corticosteroid as the first go-to drug. Confirm the diagnosis and confirm and assist the patient in understanding inhaler technique. Evidence has suggested that 5% of patients given a meter dose inhaler never takes the cap off their inhaler when they use it. Now, that's not the patient's failure, that's a failure of education. So it's not, it sounds like an absurd point, but the whole point here is no one uses their inhaler correctly. It really requires a participant sport to get in there and re-educate. Assess comorbidities, and you can also use pheno to measure if the patient's adherent, if they're T2 inflammation. Inhaled steroid is the first line. It should be used in all patients. It's inexpensive, safe. Generic drugs are available. It does affect the eosinophil count. Mild, moderate, and severe. You can see, though, as you get more severe, the responsiveness of the patient to an inhaled steroid goes down. Higher the severity, the less responsive you are. So that's important. Addition of other agents such as long-acting beta agonists, antimuscarinics, and leukotriene modifiers are helpful in some, but not all patients. Add-on, always consider the inhaled corticosteroids with and without a long-acting beta agonist. I'm a big fan of combination therapy, so I start that out right out of the box. Rather than use just an ICS, an inhaled steroid, I will use combination therapy. I truly believe the combination is safe, and it also allows you to decrease the total dose of steroid. Now, other non-biologics like tiotropium, macrolides, we'll talk about in bronchial thermoplasty in a bit. Bronchial thermoplasty, tiotropium, as well as macrolide antibiotics are very helpful for non-T2 inflammation. Macrolides are not anti-infective at the dose we use. It's typically azithromycin, 250 milligrams Monday, Wednesday, Friday. That drug affects neutrophil function and can actually be an anti-neutrophil drug and make steroids work better. So we reserve that for that 40% of patients who have non-T2. I'll talk about bronchial thermoplasty in a little bit. Now, current therapies, well, at all costs, we try to avoid oral corticosteroids. These are incredibly inexpensive. They're great drugs for people who want to take a pill and eliminate inflammation. The consequences, though, are myriad. Also, we sometimes lose track that you as the practitioner are not the only one prescribing the oral steroid. Often, if you talk to patients who have a flare of asthma, they go to urgent care centers, they get a handful of prednisone, they take it. You then see them 2 months later and may not have reported that they took oral steroids. So it's very important to ask the patient, have you had oral steroids? Have you had an exacerbation requiring an ER visit and hospitalization? The reason is severe asthma is defined by the guidelines is that patient who has 2 or more exacerbations in a given year requiring oral steroids. Only 2. Now think about most patients that you manage with more challenging asthma. They'll have an asthma attack almost every quarter or every season because of flares. That already puts the patient at greater risk for any of these side effects from oral steroids. So understanding the mechanism is where we need to go. And the mechanism can be affected by biologics. There is an anti-IgE. I mentioned that was omalizumab or Xolair. That has been around now for 16 years. But these other drugs have been recently approved, taking out IL-5. There's 3 of those. And there's one that takes out or blocks the IL-4 receptor to which IL-13 and 4 bind. That's called dupilumab. Some of you may recognize that name. It was approved for atopic dermatitis for the last 2 years, but just asthma recently. So now we have 5 biologics. So why do we have to be so fastidious about knowing which drug's the right drug for the patient? Anybody know what a biologic costs a year? $28,000 a year. And there's no end game. So if I start somebody at age 18, they could be on that drug, as in omalizumab, for 15 years. If you do the math, 15 years times 28,000 is a lot of money. These are not curative. So we really want the right patient for the right drug at the right time. I'm excited because we want to kill the drugs quickly. So I got 5 choices. Up until 4 years ago, I only had 1 choice. And everybody was taking a round peg and trying to put it in this square hole, saying, I'm going to try this. And then you had a lot of failures. Now I have 5. For the anti-IL-5s, if I give 1 dose, and in next month I measure the patient's eosinophils, and they're 0, I know I've engaged the target. But the patient's asthma didn't improve. What does that tell you? I get excited about that. Of course, the patient isn't terribly excited. But I say, you know what? The eosinophil had nothing to do with your asthma. And as a consequence, I move on to the next therapy. And I can do that within a month or 2. Before, we used to have people on these drugs for a year before we knew they worked or not. So Targeting the therapies are shown here. We just mentioned this is the one antibody that's been around the longest, omalizumab or Xolair. The anti-IL-5s are things called, this is mepolizumab, rezolizumab, as well as mepo-rezolizumab and benralizumab. These are Fasenra. Syncare is the other one, Nucala. This one, IL-4, IL-13 is dupilumab. This is specific for IL-13, and this is dupilumab is Dupinex. There are other ones that are being developed but not currently available. The approved anti-IL-5s are shown here. Benralizumab, very effective. This is sub-Q for 3 months and then every 8 weeks. It's the only biologic that we can use for every 8 weeks after the first 3 months. Rezolizumab's only an IV formulation, very effective in severe asthma. The other anti-IL-5 has been now around for 4 years, mepolizumab or Nucala. This is a sub-Q injection. This is monthly. Omalizumab is every 2 to 4 weeks. This is for allergic patients with high IgE. And this is a group that have eosinophils and high exhaled NO. And dupilumab is the only drug that's available for home injection every 2 weeks. But each of these drugs are picking and focused on one type of patient. One size doesn't fit all. This is precision therapy matched to the biomarkers that you're going to be using. Now, there's many studies that have now come out. We're looking at about 6,000 total patients. All the anti-IL-5s can decrease asthma exacerbations by 50%. More importantly, these drugs allow you to taper oral steroids. If somebody is oral steroid dependent, all 3 of these drugs have been able to be oral corticosteroid sparing. So bronchial thermoplasty, this is an interesting technique. This has been around now for almost 7 years. This requires bronchoscopy. I don't know if here you're doing bronchial thermoplasty. But what we do in the non-T2 patients with severe asthma or oral steroid dependent, we go down with a bronchoscope and we deliver a thermal energy, basically the temperature of a hot cup of coffee, and we burn parts of the airway. Now the epithelium dies, the muscle dies. The epithelium grows back, but the muscle doesn't. And what has been demonstrated is this approach, which is 3 separate bronchoscopies separated by 2 weeks, can improve exacerbation rates, oral corticosteroid spare, and improve patients' outcomes. So it is interesting. As a matter of fact, in their study, they could eliminate ER visits. Now, the beauty of this approach, it doesn't require adherence. After you're done the 3 bronchoscopies, you're done. And it doesn't extinguish. Over a 5-year study now shows those who benefited over 5 years. Tax and tags for this, $18,000. In comparison to $26,000 for the rest of someone's life. So right patient, right time, maybe this would work. It is invasive, does require bronchoscopy times 3. So what I tried to do is tell you how asthma therapy has changed. The days of an inhalers, we still have inhalers and they're still important, but we've now moved on to precision therapy. There's type 2 inflammation and non-type 2. There's eosinophilic, non-eosinophilic, and allergic and non-allergic. Using the right biomarkers, peripheral blood eosinophil count, total IgE and RAS tests will tell you whether you're eosinophilic or allergic. So, last module, how do you select these? What are the strategies to maximize standard of care? Well, still important. Allergy avoidance, allergy immunotherapy, especially in kids, is very useful. The biologics are new, upcoming. We have 5 of them, and the bronchial thermoplasty. You know what's funny about allergen avoidance? About 3 months ago, I had a patient who came in, new patient, saw them in the office, severe asthma. Asked the patient, point blank, what triggers your asthma? Then I went through all the triggers. Do you have any pets at home? Do you have any cats? Do you have any dogs? No, Dr. Panettiere, none of those. All right, so we go through and design the treatment plan. Patient goes to the nurse who is going to teach how to do the inhaler technique, because our nurses do a great job and our respiratory therapists are fantastic at teaching inhaler technique. Nurse knocks on the door, says, Dr. Panettiere, do you know the patient has a cat? I said, how could they have developed a cat from here to your office? They said, well, you asked the wrong question. It's not her cat, it's her daughter's cat. The point I'm trying to make is once you think there's no triggers, you have to figure out, are there no triggers? And in this case, the cat, she was wildly cat allergic, but didn't want to get rid of the cat because the daughter has the cat. So it is a problem. So what is your approach to treating patients with severe asthma? A personalized precision approach. You're going to measure the blood biomarkers, determine the endotype. High eosinophils, anti-IL-5 is the perfect drug. Atopic, allergic patient, omalizumab is the ideal drug. High pheno and maybe eosinophils, dupilumab is a great drug. Treat the most appropriate way to maximize the benefit. And biologics have all been shown to reduce exacerbations, reduce oral steroid. The patient who is oral steroid dependent, these drugs are really lifesavers. Improve symptoms, quality of life, and we don't know if they're going to cure asthma over the long run. We've only had the anti-IL-5 drugs for about 3 years. What happens if we have somebody on it for 12 years? Do the eosinophils just fade into the sunset and never come back? We don't know. Which therapy is best for the specific patient, and how do you choose between the biologics? Well, we talked about biomarkers, the endotype, precision medicine, and the potential need to measure whether you've engaged the target. Long-term health risks, I mean, they could be real. We don't really know. Do we need eosinophils? Certainly you need eosinophils to get rid of parasites. So if you're in an endemic area, I was in Colombia, South America, I gave a talk on anti-IL-5s, and a couple questions went up. They said, Dr. Panettiere, how frequently do I measure fecal parasites, O and P? And I looked at them, I said, wow, that's a tough question. We don't have any of them in Pennsylvania. But the point is in endemic areas where there are parasites, eosinophils are very important. Now, the interesting thing is the hypereosinophilia associated with parasites seemingly protects some people against asthma. Really intriguing. So I didn't have an answer, except the package insert for all the anti-IL-5s is if patients have active parasitic infections, you treat the parasitic infection and you can use an anti-IL-5. It's in the package insert. So you can treat while you're treating a parasitic infection. Do not know if the biologics long-term are going to be safe, but it is an interesting question. What are you going to look to in the horizon? Well, there's a lot of different things. Non-biologic therapies, there's many that are available. One is the antibiotics and macrolides. The AMAZE study, done in almost 500 patients receiving azithromycin 500 3 times a week, reduced exacerbations. I particularly use this with bronchiectasis on high-res CT scan in severe asthmatics or in those with neutrophilic asthma. One drug you're going to hear about in the next 2 years is tezepelumab. This is another biologic. This one takes out TSLP, which is a mediator of non-T2 inflammation. It'll be a one-of-a-kind if it passes through phase 3. There are others. I'm not going to go through there. There's many new biologics that'll be coming out, hopefully very specific. We have lots of questions. How do we decide between them? Well, I gave you some clues there. How do we decide between biologics for patients that meet different therapies? How long do we treat? How do we combine them? I don't have any of those answers, unfortunately. We need a lot more research, and we have to compare comparative efficacy studies, comparing one anti-IL-5 to the other, and what is the risk for relapse. So today I just went through a lot quickly in severe asthma. First takeaway, Used to be all about inhalers. We're in a new era. Precision medicine, measuring biomarkers in the periphery, predicting therapeutic response, and more importantly, showing we've engaged a target is new medicine. We've never had that before. Remember, when you gave a beta agonist for rescue, no one in this room measures cyclic AMP levels in the patient, right? Or we activate the beta-2 adrenergic receptor. When we give insulin, we're not really measuring whether we're activating the insulin receptor. All we know is the outcomes. Now we're determining that we can actually measure the action of these drugs. Biomarkers can predict endotypes, mechanisms of disease. Guidelines are going to embrace these therapies, and we need to screen patients for the right drug at the right time. Remember, kid asthma is different than adult asthma. And we have to use the right therapy. Biomarkers are needed to identify the most appropriate therapy. So what I want to do is thank you all for being so patient and kind for this invitation. Hopefully it's elucidating precision medicine is here. It's beyond cancer, going into other chronic illnesses, and it's an exciting time to take care of these very affected individuals. Have a great afternoon. Thank you so much. Yes?
Why do you say so many people misuse their, why do so many people misuse their inhalers?
Yeah, so the question is, why do so many people misuse their inhalers? Inhalers are not easy to use. They're really quite complicated if you think about it. So it's about 8 steps in using an inhaler. Now, if you open a bottle and you take a pill, it's pretty easy, unless it falls on the floor that you got it into your mouth and you swallowed it. But the inhaler, all inhalers, by the way, are suspensions, so they have to be shook. The cap has to come off. You have to keep it outside of your mouth, and at the end of expiration, you have to take a slow breath in, actuate the inhaler, finish the breath, and count to 10. 5, 4, 3, 2, 1, and blow out, and then repeat that. Pretty complicated device. Things get dirty. If you have a spacer, people don't complain about their spacer until the thing on the rubber end, the plastic tube no longer fits the inhaler. But you look at it and it's grimy and green with algae, and they're inhaling this. So you're like, you know, that spacer should be renewed every 6 months. The tops come off and you put it in the washer. Or you wash it with soap. There's a lot of effort here involved, much different than opening a cap of a tube, a bottle, and taking a pill. So it's a very complicated device that just requires frequent education. Great question.
How about exercise-induced asthma?
Yeah, so exercise-induced asthma is interesting. There's 2 flavors. There's patients who have no asthma at all except when they exercise, all right? Those are very interesting patients that probably have neurogenic asthma and not inflammatory asthma. So inhaled steroids won't work, but beta agonist 20 minutes before the exercise is very effective. So in those, or you can even use a drug like Monteliacast sometimes. Neurogenic asthma or mediated asthma is much different than inflammation. So why did I say 2 flavors? Well, there's that patient with intermittent asthma, and then there's the patient who has garden variety inflammatory asthma that also wheezes upon exercise. So this patient, if you measure their FEV1 in your office, it's going to be 90% or better. It's going to be normal. This patient could be 70, 60%, exercises and gets more asthma. That patient I treat with an inhaled steroid long-acting bronchodilator and Phenotype. Both will come to you and complain, I have exercise-induced asthma. One is garden variety uncontrolled asthma, where exercise is a trigger. The other, exercise is a trigger, but it's just neurogenic and not inflammation, so I wouldn't use a steroid here. Great. Thank you very much. Appreciate it. Have a great day.